Okay.
Okay.
How are you, Mark?
I'm very well. Very well. I'm nice to see such a good audience.
Okay. And good evening, Javier Bueno. Javier, friend, in Barcelona. How are you?
Cannot talk. Now, yes. I am fine.
Fine, okay.
All of you.
Okay. And in USA, Pablo Laje. Good morning, Pablo. How are you? Here in the room are Mariano Boglione. He's surgeon of the pediatric service in Hospital Garrahan. Surgeon Silvia Taqueda. She's surgeon of the pediatric service. Carolina Perez. She's chief resident of pediatric surgeon in Garrahan Hospital. And together, Guillermo Servio, he's surgeon of the liver transplant program in Hospital Garrahan here. The development of the Zoom will be first a biliary Atresia lecturer by Professor Mark Davenport for 30 minutes. And after, we will open some questions for discussion. We receive question and comment, Carolina, in the chat. In Spanish or in English?
Either way, we'll translate.
Okay. Okay, Professor Mark Davenport.
Okay.
I shall screen for your lecturer.
So let me share my screen now.
Horacio, después abrirle a Pablo el micrófono.
¿Cómo le abro?
Okay. Can you see that?
Yeah.
Can you see that? Any problems?
It looks great.
That's Trafalgar Square in London.
It's good.
Wait.
That's Lord Nelson at the top of his column. Thank you very much for inviting me to give this lecture. I'm doing this in London at the end of a very long, hot COVID summer, and obviously by the miracles of modern technology, transmitting to you down in Buenos Aires. I have been given a list of things to do. I'm going to talk about diagnosis. I'm going to talk about the variants of biliary atresia. I'm going to concentrate a little bit on the surgery, the technicalities of the surgery, and we're going to address some controversial areas on adjuvant therapy. I've also been instructed to talk about what to do with the older infant, and then therefore introduce the concept of a primary transplant. Now, this is a graph that's taken from a paper we published last year. We looked at all the literature of biliary atresia, not for its content, but for who produced it, where it was produced, where it was published. And it shows us very clearly that biliary atresia is a hot topic. There's been an almost exponential increase in publications and citations over the past 20 years. It's a very important key area. Now, most of the publications do end up, admittedly, in the Journal of Pediatric Surgery, but there's nothing wrong in that. You've got two editors, in fact, contributing to this presentation today from the Journal of Pediatric Surgery. But we also get articles accepted in much more high impact journals like The Lancet and Nature as well. So let's agree on a few ground rules. Biliary atresia is progressive, it doesn't get better. In about half, there is a marked inflammatory component, and the biliary ductules tend to get smaller or have never even developed in the first place. This process not only affects the ducts we can see outside of the liver, but also those inside. And fibrosis is a key element. It's time dependent and ultimately will lead to liver cirrhosis. And the disease remains the commonest cause of liver transplant in children. And if you put all that together, you could use the phrase panductular cholangiopathy to describe it. Now, if you look at the world, biliary atresia is not spread evenly. In my part of the world, in Europe, the incidence is about 1 in 17 to 20,000. That's probably true of North America as well. But if you go to the Far East, specifically Taiwan, their incidence is 1 in 5,000. They get as many biliary atresia cases as they would do esophageal atresia and exomphalos. We don't really know what the incidence down in South America is. Only you will really know that. So let's take an actual case as an example of the typical process. So this is a baby born after a normal pregnancy with a normal delivery and a normal postnatal pathway past normal meconium. But on day 30, the baby is still jaundiced. And it's got a key characteristic sign of pale stool. And we at the biliary atresia end clearly start to be worried about this. Is it a possible case of biliary atresia? The pale stool clinically discriminates from all those other babies that don't have conjugated hyperbilirubinemia because there's no bile in the GI tract. So here's the representative blood result from this particular baby. A high proportion of conjugated split bilirubin. So what next? Well, you probably have to involve other people, typically medical people, physicians, neonatologists, pediatricians. And their main role in this is to exclude other medical conditions. And there's a whole list of possible medical conditions that can mimic the baby with surgical biliary atresia. Most people would then get an ultrasound. And the key things we're looking at is there a cyst present? What are the state of the intrahepatic ducts? Now in biliary atresia, that's not going to be helpful because the intrahepatic ducts in biliary atresia do not dilate. If you have got visible intrahepatic duct dilatation, that may well be due to a surgical cause, but it won't be biliary atresia. So an obstructed choledochal cyst or inspissated bile syndrome may lead to that. One other important feature is the gallbladder. In biliary atresia, they're usually atrophic or abnormally shaped. But also, you can also get a normal shaped gallbladder, even in biliary atresia. And when you come to surgery, you'll see that it doesn't contain bile, it contains clear mucus. And that can fool the unwary. Now, I've put something called the triangular cord sign here. That's a very disputed ultrasound sign. It was invented in Korea, and some people believe in it, some people don't. We look at the liver parenchyma. Is there any evidence of fibrosis and cirrhosis? We look for evidence of something called the biliary atresia splenic malformation syndrome, BASM. We look if they've got evidence of polysplenia. We look what the situation of the portal vein is in relation to the duodenum. We look if they've got situs inversus, a key feature found in about half of babies with BASM. But still, it's difficult to come to a real conclusion and diagnosis. So what else can we use? Well, I've listed a few possible alternatives. Some units will do an MR scan at this stage. I don't think the MR technology is really advanced enough to be able to diagnose biliary atresia unless really there's a cyst. So we tend to reserve it in those kind of cases. Some people use HIDA, radioisotope scans. Again, we used to use these over 20 years ago, but found they weren't that discriminatory. There may be one instance where it might be helpful, typically in the small baby, the baby that's come from a neonatal intensive care unit, the baby that's had parenteral nutrition, and we want to try and exclude biliary atresia. So we're using it as a method of exclusion more than actual diagnosis. ERCP, some units have got ERCP. We have in London. And we will use it in selected cases, not all cases, but selected cases. we rely actually on the liver biopsy, and a lot of centres in Europe and North America rely on a percutaneous liver biopsy to try and arrive at a diagnosis pre-laparotomy. And then we still have to confirm it. And the only real way of doing that is to look at the liver and the bile ducts and the gallbladder. Some people would use a laparoscope for this, which is fair enough, and do a cholangiogram. I tend to do a sort of mini laparotomy, a small centimetre incision just over the gallbladder itself, and that will enable me to make my mind up whether to continue with a Kasai operation, all under the same general anaesthetic. So our protocol, we try and aim for an early diagnosis, and we use liver biopsy plus or minus ERCPs. Most of these infants will be offered a Kasai portoenterostomy, and if that fails, we will do a liver transplant. A small proportion, and I'll tell you how much exactly toward the end of the presentation, because of overt changes of cirrhosis in their typically older infants, we will offer them a primary liver transplant. The whole process is designed to be complementario, and seamless. Everything should fit together. Okay, let me give you another case, another example. This is a baby, again, with a normal pregnancy, but an abnormal antenatal scan. You can see on the right-hand side of your screen what looks like a double bubble. Well, to everyone, to every surgeon at least, that's a duodenal atresia, obviously. But this case really didn't have polyhydramnios, which is a little bit unusual. And there's the baby that's just been born, and a nasogastric tube was sighted, but again, no bile. It was clear. Again, unusual. So we did an ultrasound, or an ultrasound was done. This was in a referring hospital. And this made it clear that actually it wasn't duodenal atresia. It was a cyst arising from the porta hepatis, really quite a large cyst. So the baby was actually transferred to King's. Now, at this stage, it's important to know whether the baby has genuinely got conjugated jaundice or not. So this is a baby at about 2 weeks of age, and indeed, the baby was jaundiced. So we did what I said we would do, which is to do an MR scan. And these are a couple of images showing a very large cyst arising from the porta hepatis. So with that and conjugated jaundice, you've got a differential. It could be a cystic biliary atresia, but it also could be a straightforward obstructed choledochal cyst. Now, actually, in the presence of jaundice, conjugated jaundice, it doesn't really matter. Both these instances will need an urgent laparotomy, and the diagnosis can be made at that time. Some choledocals clearly are not jaundiced, and you've got a bit of a waiting period in order to arrive at a diagnosis. But even in those cases, I tend to only wait 6 to 8 weeks before doing elective surgery. So this is the laparotomy. This is a cholangiogram of that baby. And the cyst itself contained mucus, large cyst containing mucus, no bile. But if you look at the cholangiogram, you can see, I believe, if my 8,000 kilometer TV screen allows me to project it, there are abnormal intrahepatic ducts, very fine, distorted, abnormal ducts. And this is a case of cystic biliary atresia. This is another case of cystic biliary atresia. You can see in this case, we've got the cholangiogram catheter. There's the cyst. This thing here is the cyst. There's the gallbladder, completely solid, unlike that of a choledochal cyst. So this is cystic biliary atresia. And this is the cholangiogram that came with this one. And again, you can see this very abnormal intrahepatic duct profile. Now, we reported our experience back in 2008. And at that time, we had 10% of our series overall were of this type. Half of them almost were antenatally detected, and a minority, 21%, contained bile. So they can contain bile. Now, in terms of good or bad, they're actually a good type variant of biliary atresia. They do well if you do a proper Kasai operation. And you can see this is a comparison actually taken from our UK series. So there's a lot of infants in this particular graph, comparing them with the anomalies biliary atresia and the isolated biliary atresia. And they've got a much better outcome in terms of native liver survival. What we've observed actually only relatively recently is it may not last. You can see the staircase coming on as more and more of these are transplanted in adolescence and early adulthood. So cystic biliary atresia is certainly better initially, but they may not last. And that brings us to the topic of variants. Biliary atresia is not a single disease. We described one of the syndromic forms of biliary atresia a long time ago now, that's BASM. There's another one as well, the cat eye syndrome as well. Cystic biliary atresia I've talked about. One we've actually spent a long time investigating and characterizing over the past 10 years is a baby that's got IgM antibodies against CMV. And in our experience, that's about 10% of these babies. And they're older at presentation. They've got a higher degree of liver fibrosis and actually a poorer prognosis. And I'll illustrate that in a moment. So CMV IgM positive biliary atresia. Now, of course, the majority actually have none of those features. And we label those as isolated biliary atresias. So these are the ones likely to actually you see in real life. Now, I only do open Kasai portoenterostomies. I know there are a few mavericks and cowboys that will do the laparoscopic Kasai operation, and we can argue about that at the end. But most people will do an open procedure. The only real decision, I think, is you can do the dissection, I believe, best when the liver is delivered out. But you can leave the liver in and do a perfectly competent dissection there. Maybe it'll take you a little bit more time. Okay, so let me just show you a very short video of just how to take the liver out. This is me extracting the liver. I've divided the falciform ligament. I've divided the left triangular ligament. So we hook the finger over the left lobe and slide it out of the abdominal cavity. And then the right lobe will come as well. We don't have to mobilize the right lobe. And as you can see, it's stable. We can splay open the contents very nicely. And there's the porta hepatis, and that's where all the key dissection is going on. Now, at this point, you've got to keep the anaesthetist awake because you've reduced the venous return from the cava, and they may need to support the blood pressure. So this is what it looks like, and it's maximally invasive surgery. So we've dissected a little bit, and the key dissection principles is to separate out the remnant biliary tree from the vascular structures within the porta hepatis. And in most cases, we will open the rex fossa to achieve that. You can see the rex fossa over here. This is the umbilical vein. It's going down to become left portal vein. Sometimes there's a bridge of liver tissue there. We will divide it. And it allows us to get a few more millimeters into the left side of the porta hepatis. On the right-hand side, we're into something that I'll talk about in a moment. The portal vein is usually tethered to the lower bit of the biliary remnant by some veins, two or three little veins, which we will deliberately ligate, allowing us to push the portal vein down. And then on the right-hand side, this is the right side, this is what's called Rouvier's fossa, and this is where the posterior branch of the right hepatic artery and right portal vein go into. And between the posterior bit and the anterior bit, there's a little triangle of biliary tissue as well, which we'll also incorporate in our portoenterostomy. Now, this is the transection phase. This is halfway through the transection phase. There is the plane that we're trying to achieve. So we've started on the right, we're going towards the left, and we've reached that point. That is biliary duct, and that's going to be stripped across. So this is the plane we're aiming for. And when we successfully achieve that, there is no more biliary tissue to take away. And that's why frozen sections are irrelevant. You can't get any more tissue out. I don't want to go into liver tissue. I've got a millimeter or so, or less than a millimeter, but I don't want to core out this bit. That's a very unstable interface, and they don't do well. So this is the surgical interface that we're trying to achieve. And once we've reached that phase, then all of that is going to empty into our roux loop, all of that from Rouvier's fossa over here to the rex fossa over here. And this schematically just illustrates what a radical portoenterostomy is. Okay, now what next? Well, we've got a number of different options. Everyone will use antibiotics. The only real discussion is how long do you keep oral antibiotics as a prophylactic for. Typically, we would only keep them for 4 weeks actually at King's, but I'm now starting to change my mind that that's probably too short. So our babies are now getting prolonged courses of antibiotics, but I've got no evidence for that. Ursodeoxycholic acid derived from bear's bile. Now there's a single paper, a randomized crossover trial of urso showing biochemical benefit, but it only really works if you've already established bile flow. So it doesn't improve the jaundice clearance, but it might help you in the longer term to maintain the liver. Steroids, this is the controversial area, and I'm sure you'll all have your own theories, feelings about steroids. I'm a believer, obviously, and I'll show you why in a moment. I'm also a believer in antiviral therapy now, and again, I'm going to try and show you some evidence of this as well. Obviously, the virus is CMV, that's the thing we're trying to treat. Okay, so let's talk about steroids for a moment. Now, steroids have been in practice for about 20, almost 30 years. Started in America, and there's two big experiences, and I'm going to illustrate in this slide. There's the START trial. This is a North American multi-center, randomized, placebo-controlled trial of high-dose steroids. And I think high dose is where you really have to start using steroids. This is the mean age of this particular trial. It's quite old, certainly by comparison to Europe and Japan. 69 days is a mean age. Those are quite old infants, and that may be important. That's the level of clearance of jaundice that they were used, and they recruited 140 babies into the trial, half of which had steroids. And what you can see, the number is the clearance of jaundice rate. So 59% in the steroid arm and 49% in the placebo arm cleared their jaundice, a difference of 10%, but it wasn't statistically significant. And then they had to do a subset analysis just by limiting it to the younger infants less than 70 days. But obviously that's wiped out half of the numbers. So in this subset analysis, in the steroid group, 72% cleared their jaundice. This is fabulous, 72%. 57% in the placebo arm, a difference of 15%, but not statistically significant. So they threw the baby out with the with the bath water. That's a good English idiom, and said steroids make no difference. Now this is our experience. I did a randomized controlled, placebo-controlled trial in the early 2000s using low-dose steroids, but then we moved on to an open-label trial using high-dose steroids, and this data is taken from that. So these are only younger babies, all less than 70 days, and look at the numbers, 153 in this, and in our steroid group, 66% cleared jaundice versus 52% in the controls. And it's the same difference. It's the same difference. But the statistics showed us ours was significant. So the two biggest experiences in the Western world show the same difference. And the question is, do you think a difference of 14, 15% using steroids is worth it? Okay. Now, age surgery is important, and I'm going to show you some statistics in a moment, but just to preempt that, this is what's called an age cohort analysis. So this is our steroid group split up into the age at surgery. As I said, they're all less than 70 days. But these are the youngest group. These are all less than 30 days. And this is y-axis is percentage of clearance of jaundice. And in this group, all less than 30 days, 100% cleared their jaundice. In the opposite extreme, 61 to 70 days, which is this group, 66% cleared their jaundice. And we've got these three intermediate groups as well. Now, if you combine the results going from left to right, then you get this cumulative black line. And if it's falling, that implies there is an effect of age on outcome. And as I say, this is the steroid group. Now, if you look at it as a chi-square, it doesn't quite reach significance. But if you look at it, and you should look at it for trend, because there is obviously a relationship between each cohort, then the trend is significantly in favor of an effect of age on outcome. Now, there's two or three actually meta-analyses. They're not really meta-analyses, of course, but they're pushed as that, of steroids and biliary atresia. So this is I've taken this from one of them. So this summarizes all the previous experience, and this is statistically significant. So meta-analysis suggests steroid therapy improves jaundice clearance, and also that there is a significant effect of age on outcome using steroids as well. So again, if you believe meta-analysis, that would make it in favor of using high-dose steroids. Let's try and move on to another aspect that we might be able to do something about. Cytomegalovirus, CMV. It's a double-stranded DNA. It's capable of infecting bile duct epithelia. And with a great deal of difficulty, you can actually isolate the DNA from babies with biliary atresia. Now, we've produced 4 papers, in fact, on CMV and biliary atresia. This is the last one in the December edition of the Journal of Pediatric Surgery. And this is concentrating on therapy, treatment. So these are our figures. So since 2003, we've had 36 infants, not a big number, I have to say, of CMV plus who've had a Kasai operation. In 28 of them, we didn't do anything other than a Kasai operation, maybe a touch of steroids by accident. In the others, and these are obviously the ones that are later on in the series, we did consciously try and treat with antiviral therapy. Now, initially, they got IV ganciclovir and then valganciclovir, but in the last 3 of this series, we actually just treated them with oral valganciclovir, which is obviously technically much easier to do in babies. So let's see what the results of that therapy was. Well, as I intimated before, CMV and biliary atresia is not a great combination. So in our controls, only 21% cleared their jaundice, 21%. This is terrible. In those that we treated in addition with antiviral therapy, 6 out of 8, 75% cleared their jaundice. And even though the numbers are tiny, that was statistically significant. And it also reduced the need for transplantation in these groups. This is the native liver survival. And again, the heavy black line is antiviral therapy in addition to a Kasai, and you can quite clearly see the difference. Okay, so let's move on to some science fiction, perhaps. This year, I wrote an article for Translational Pediatrics on the subject of adjuvant therapy for biliary atresia. And we reviewed a number of different things that are on the cusp of being used or may be used in the future. Someone asked me to talk about the PRIME trial. PRIME was done by the North American Children Network, open label, no real controls, and certainly no placebo. They got the controls from the previous START trial, actually. But they used it in 30 infants. And they said, bottom line, there was no effect on clearance of jaundice. So they had high hopes that this might influence the inflammatory nature of the disease. It does not seem that that's going to happen, and I don't think this study will be repeated. There are a number of other agents, however, that may be coming to clinical practice, and I'll say in about 10 years' time. Obeticholic acid. This is a farnesoid X receptor agonist. It's used in adult practice for primary biliary cirrhosis, sclerosing cholangitis, and the company do want to use it in some infantile cholestatic conditions such as biliary atresia. And there is a trial that's being constructed for the moment. It won't have any effect on the increased proportion to clear their jaundice, because I think that's an anatomical issue, but it may have a role in keeping these infants going with their native livers, obeticholic acid. The other agent that, again, there's drug companies are interested in now is maralixibat. This is one of the bile acid transporter inhibitors that is working on these ileal receptors. And it's actually in current use now in things like Alagille syndrome and PFIC, and actually has very good outcomes in these 2 conditions. And the company, again, trying to use it in biliary atresia. So again, there's a trial in construction for maralixibat in the next few years. One that is at the very early stages, a thing called emapalumab. This is a very hot drug that is an anti-interferon gamma. And it's used in a number of different conditions, albeit very rare conditions, to stop the inflammatory process at source. And there's a lot of experimental evidence that interferon is a key molecule in the inflammatory condition of biliary atresia. So we are in early negotiations with the company that makes this, and perhaps using this in some clinical cases, emapalumab. Okay, so I'm on to my home straight now, and I'm going to show you some figures that are derived from UK practice, well, actually England and Wales practice. As you know, we've centralised our treatment of biliary atresia since 1999. So there's only 3 centres actually in the entire UK and Ireland which now do Kasai operations and also do paediatric liver transplants for biliary atresia. So all of the infants, at least in England and Wales, came to this one of these 3 centres. And that's a big series, 867 infants since 1999 to the end of last year. So from that database, I've extracted this just to illustrate the effect of age. Now, I showed you an age cohort analysis picture before. This is another one now, but on a much bigger group of infants, those with isolated biliary atresia. And you can see I've taken it out to 100, actually 100 plus days. So all of these represent distinct age cohorts. So as you can see, the black line is falling. And that implies an influence of age on outcome. And in this case, the outcome was clearance of jaundice. And that is strongly statistically significant. Now, what I was asked for was what to do with these older infants. So this is 2 age cohorts that are 80 to 100 days old and 100 days plus. So these are the really bad biliary atresias that come to your clinics far too late. Now, the first thing that you can see from this graph is actually a significant proportion are clearing their jaundice. They've all had Kasais. So the clearance of jaundice rate in these infants, 80 days plus, is it's just under 50%. It's about 45 to 50%, which ain't bad, So I wouldn't give up the Kasai because it won't work or it's inevitable to fail, because that's not actually true. So that's what happens when you do a Kasai for these infants. Admittedly, these have all had a Kasai, so we've separated them out somewhat. They come from, as I say, a group of over 800. And this is the proportion of our infants who were more than 100 days at Kasai or at presentation. So in the first part, and I've divided these into 4 eras, in the first part, 7.3% did, which is not an insignificant figure. By the end of the period, however, it was down to about 4%. So we'd improved the proportion to present these older age groups. So what happened to them? Well, this graph is the same graph, but colored according to what happened. So the green is they had a Kasai, and the outcomes I've already illustrated. And the blue, we put forward it for primary liver transplant. So as you can see, the proportion overall of primary liver transplant is about 4% of the whole group, and it hasn't really changed. As a proportion of the late comers, it's relatively got greater, if you can understand that. But still, the majority of cases will have an attempt at a Kasai operation. Now, if you're putting people forward for a primary liver transplant, you've got to take into consideration of where the donor comes from. And if you haven't got an easily accessible living donor, and many of these parents are not suitable for that, then you've got to wait for a cadaveric donor. So in this period of time, the median age at liver transplant was 230 days. Now that's quite a long time. And if you look at the IQR, the interquartile range, it implies that a quarter are over a year of age. A quarter are over a year of age at the time of their primary liver transplant. And clearly that exposes them to a risk of death. So you've got to have your donor handy for these. So we will consider a Kasai. I would also recommend it if liver transplant is not an option. You've got to do something. Liver transplant, we try and make a clinical decision based on examination and ultrasound. If they've got hard hepatosplenomegaly implying significant portal hypertension and ascites, we will probably fast track them to primary liver transplant. And again, we've got to make thoughts about where the donor actually comes from. So if the parents are willing to be living donors, then they would probably tip the scales for a primary liver transplant. Okay, so what can we conclude? What can I conclude from my presentation across 8,000 miles of Atlantic Ocean? Well, I've talked about the variants of biliary atresia. That should always be borne in mind if you're the surgeon that's operating on these, because you might be surprised. You might find to your cost that actually this is a splenic malformation type of biliary atresia because the actual bile ducts are different. Cystic biliary atresia are relatively straightforward. CMV-IgM positive, you've got to do the blood test to find that out. I've talked a little bit about the surgery of biliary atresia. I'm a firm advocate of radical resection for this. And that's not really an option if you're going to do that laparoscopically. The foremost proponent of a laparoscopic Kasai is a guy called Yamataka, working in Tokyo. And he doesn't do a radical resection. He simply transects the biliary remnants at a much more superficial level, leaving an oval kind of shape. And that's what he does, the anastomosis with the roux loop. So it's not quite a radical resection. Adjuvant therapy, obviously, there's a lot of arguments about how successful this is and how can you influence it. Antibiotics are invariable. Steroids I clearly believe in, and I think there's evidence for it. So I think you've probably got to be a believer for that one now. So I'm going to leave it there and hand you back to Buenos Aires, and hopefully my voice won't give out too much in the next few minutes. Thank you very much. Happy to take any questions.
Thank you very much, Mark Davenport, excellent lecturer. Okay, now open the discussion, open some topics for discussion. I invite Pablo Laje for development this part of the Zoom for discussion. Pablo.
Yeah, I'm here. Well, thanks.
Okay.
Thank you very much. That was an awesome lecture, Mark. That was great. Excellent summary. There's so much that we still need to learn, I guess, right?
You've stolen my paper.
No, this is not me. I haven't done this PowerPoint. Okay, Horacio, do you want Mark to answer questions from the audience, or you want to go through the PowerPoint?
Si querés que te conteste las preguntas de la audiencia o seguimos con el PowerPoint.
Hay dos preguntas.
There is two questions.
Okay.
Carolina?
Mark, here they ask do you have the analysis of infections and growth parameters between babies who have received steroids of those who haven't?
Okay, so let me interpret that. So these are the steroid group, yes?
Yes.
And you're asking, do they have a higher incidence of any infection, yes?
Yes.
Yes.
Okay, no, they don't. So our experience was against that. We didn't find any increase in steroids, in infections, cholangitis specifically, in the steroid arm. We did a very thorough randomized controlled trial, as I alluded to earlier, back in the early 2000s. And these babies were seen very frequently, and they were no different.
Horacio, ¿querés que te segunda o está bien?
It's okay, Pablo.
Okay.
Other question.
What is the cord that you use for the cytomegalovirus disease, for the association with biliary atresia?
Yeah. So nowadays, we've got a lot of pediatric hepatologists at King's. We may have only one surgeon, but we've got a lot of pediatric hepatologists. So the number of different protocols that we followed was quite high. Now, we are simply giving them oral valganciclovir. So in addition to the IgM screening test, we will quantify the viral load. And there are some of them that have got a very low viral load, and we won't treat those. But those that have got a high viral load, we clearly will treat, and we will use oral valganciclovir. For how long is dependent on the hepatologist, I have to say.
Okay.
Perfect.
Pablo, we continue with the topics of the discussion in the PowerPoint.
Okay, that sounds good. As regards this first slide, I think Mark already discussed most of the aspects. I wanted to ask you, Mark, do you think to some degree the better outcomes observed in babies with cystic biliary atresia may be related to the fact that they are picked earlier, they're found earlier, often prenatally?
Okay, so that may be a factor, and they do come earlier. Half of them are antenatal, so there is a better lead-in time. But actually, when you look at it, there's such a clear difference that when you do a correction for age and compare them with the isolated group, there is still a difference. So I believe they do better because they've got a better intrahepatic duct. It's more formed than the typical example that we see in isolated biliary atresia. So the ducts at the level of the transection are bigger, or the ductules are bigger. And I think that's probably why. As I say, it was an observation to us when I looked at the longer term, however, that even if you've got cystic biliary atresia, you're still not cured.
Very, very interesting. Okay, pasamos the next slide.
Pablo, I like question of Javier Bueno. Javier Bueno, do you treat cystic patient with cystic biliary atresia? Javier. Listen to me, Javier.
Yes, and you are, do you hear me?
Yeah.
Yes,
Okay.
yes.
Okay, yes, I have a lot of questions and also some commentaries. We treat cystic biliary atresia.
Okay.
Do you hear me?
Okay.
So my question to
thank
Mark
you.
is, my question to Mark is how does he treat that? He remove the cystic or the cyst, and do a regular Kasai, or he tried to make the anastomosis to the cyst?
Yeah, that's a very important surgical point. At the beginning of our series, and I'm talking in the 80s and early 90s, for those with bile, we would simply do a cyst onto the roux loop, as you might do for a choledochal cyst. But gradually we thought that's not going to really work. And so now we do a straightforward Kasai resection. Okay. So they end up with a denuded porta hepatis as you would do for a regular isolated Kasai. Mm-hmm. So no part of the cyst is left.
Good. So,
okay, Pablo, translate this point in Spanish. ¿Podés hacer brevemente lo que dijo? Mark dice que sus atresias de vías biliares quísticas tienen mejor evolución que la atresia tipo 3, sí. Es así. Y Javier Bueno le preguntó si en el tratamiento de la atresia de vías biliares quísticas hacía la anastomosis al quiste o hacía directamente una portoenterostomía, y dijo que hace una portoenterostomía. Pablo, next slide.
I think yes, obviously Mark already discussed these issues of what images are the way to go. Are there any questions about the images before we make some comments? Okay, if there is no questions. Yeah.
Excuse me, Pablo.
What is that?
What is that?
Have a question. Mark and Javier Bueno, do you use MRI for diagnosis of cholestasis? In this case, this patient, a patient with 40 days old boy with cholestasis, in these pictures exist right bile duct and left bile duct, and exists common bile duct finally. This study, MRI, discharged the diagnosis of biliary atresia. Javier, do you use MRI?
No, Horacio, we don't use MRI. We just use ultrasound.
The issue with the imaging studies, I think Mark said before that he would only use it if there's a cyst involved, and he showed that case with a humongous cyst, with a large cyst. But the problem with the images is that what to do with the information. I think, if you have, for instance, if you do a HIDA scan and there's, excretion of the bile into the bowel, you can pretty much rule out biliary atresia. But for all the other instances, you will eventually need the biopsy. I don't think you can possibly avoid an exploration if you, for instance, have an MRI that says, yeah, it looks okay. Are you not going to go ahead with the biopsy? So I think the ultrasound is very helpful. The HIDA is very helpful, but eventually I think the biopsy is what is going to guide you. And unless you have very low suspicion for biliary atresia, you will always end up doing a biopsy. In fact, I was going to say that the biopsies that we do here at CHOP, at least, are in clinic with the patient awake, and is an outpatient thing. So it is, I'm not going to say as easy as an ultrasound, but it's not an operation. It's really straightforward. Do you use biopsies, Horacio, over there for the definitive diagnosis, or the diagnosis to go to the operating room for a cholangiogram?
Not in the preoperative diagnosis. Yes, in the intraoperative.
So what makes you go to the operating room? What do you use to say, okay, this patient has to go for a cholangiogram?
In the next slide, discuss this point.
Okay.
Cholangiography, open and laparoscopic.
Preguntarle si confía al 100% en la biopsia hepática
y en la MR.
No, so here's so I think what Mark said before is that, and what we would do here is that we do the biopsy, and the biopsy will point you in some direction. It will say there's ductal proliferation, there's breaching fibrosis, all those things, which will in turn make you go to the operating room for a cholangiogram. I don't think you can say 100% biliary atresia or not, but if you rule it out, you can say this biopsy is not consistent to biliary atresia, and you can then not go to the operating room. Am I saying the same thing that you do in London?
Yeah.
How about you, Javier? Do you also do a biopsy to decide whether to go or not to the operating room?
Sometimes, not always. But I think most of the time we try to perform a liver biopsy. Mm-hmm. But if any doubt or looks like that seems biliary atresia, then we go to do the intraoperative cholangiography. We don't perform by laparoscopy the cholangiography because we believe that you need to clamp you need to do a Pringle maneuver to do the cholangiography, because otherwise you can have some false positive results. In those cases that the biliary is very hypoplastic. So if you don't clamp the hilum, the contrast go directly to the duodenum, and then you can have a mistake.
So you completely you clamp the entire
yes
maneuver to force the contrast up.
We pass a vessel loop.
Yeah, I see. And then Horacio, here, yeah, decime.
No, in Garrahan Hospital, we don't perform a biopsy, liver biopsy preoperative. We perform for the diagnostic of biliary atresia is very, very important, the clinical aspect. First, the pal or a colic stool, and after the cholangiogram. For we is very, very important, the cholangiogram. In this case, we performed the cholangiogram, laparoscopic cholangiogram. And in the same operative room, biopsy. If the diagnostic is biliary atresia, continues with the Kasai operation. Silvia Takeda want to have a question.
Sí, Pablo, how do you make the liver biopsy at the office?
It is with a in fact, we don't do it. It's the gastroenterologists who do it. Is with the patient in clinic, and there is you know, they don't even use ultrasound. They put some EMBLA, like local anesthesia, give the baby some sweet stuff to drink, and they use a core needle biopsy. I've seen it many times. So it's in clinic, patient comes in, gets the biopsy, goes home, unless there's, you know, maybe a question of bleeding or anything like that. But it's a pretty simple deal. It's a very simple procedure. And of course, like Horacio said, the definitive proof is the cholangiogram. I mean, I think everybody here agrees to that. I think we were discussing what would be the use of doing the biopsy prior to putting the patient under anesthesia, if you can rule out a biliary atresia with a biopsy. And then Horacio, I can see in this slide that you did the cholangiogram laparoscopically. Do you proceed with a laparoscopic Kasai afterwards, or you just convert?
Yes, no. We convert open surgery for the Kasai.
Okay.
Pablo, in general, do you treat patient with biliary atresia, young patient with biliary atresia?
Yeah.
Less than 30 days. Less than 30 days of life.
I mean, we treat them whenever they come, but because of the fetal center that we have here, we often pick early the cystic one. So we have a number of early ones, but just the ones that are cystic. Other than that, it just only depends on whenever they come.
Okay.
Mark,
okay.
Right?
So,
any comment?
Yes, I would like to say that we perform a mini laparotomy, and sometimes we don't perform the cholangiography because you see that the the gallbladder is Atresia. So you go forward for the Kasai procedure. No, we don't perform always the cholangiography.
I think that's a very important point, actually. Because they've screened out most of the ones that aren't biliary atresia, I would only do a cholangiogram in maybe 5% of the ones that come to theatre. And that's precisely the reason. Either the gallbladder's got clear mucus, it's got to be biliary atresia, or there is no gallbladder. It's so atrophic you couldn't do a cholangiogram. So although the cholangiogram is clearly the gold standard, you're trying to exclude something rather than the actual diagnosis. The one I can see in front of me, I'm still not sure what the diagnosis is supposed to be, though, because it's all going downstream. So it's not going where you want it to go, so that could clearly be biliary atresia.
Mark, one question. Do you clamp the hymen?
Yeah.
Or not?
So it's very uncommonly do I have a real problem. And the ones that I've had a real problem with are hypoplastic ducts. We've done the occasional allogeals, or it's turned out to be allogeals later on. And they've got very, very little. They're not inflammatory at all, and they're very, very fine ducts. And sometimes you just can't see contrast going back into the liver. And for them, I won't do a Pringle necessarily, but I will consciously try and clamp the distal duct, yes. Because you say you've got to be, for those where you're not going to do a Kasai, you've got to be absolutely secure in your diagnosis before you leave the operating theatre. So it's very important.
ERCP le hacen todos, dijo, ¿no?
¿Cómo?
Question, ERCP for diagnostic.
Very rare. Very rare.
Mark, yes.
Yeah,
we Javier?
It depends if you've got the scope, to be honest. So we've got a full range of services for the RCP. Our endoscopists have a long history of doing it in babies, so they're very happy to do it. But if you're only doing one a year, it won't work. The other problem is the manufacturers have stopped producing the equipment. So it's not a thing for the future, I'm sure.
No, in our case, we are not doing because we don't have instruments, appropriate instrument for that age.
Javier, it's very difficult, the endoscopist, pediatrician endoscopist, no? For performing ERCP.
Yeah, but actually, I don't think that the device, the endoscopy has been made for neonates or infants. So I think it's not easy. We have our endoscopists are really good. Those who perform ERCP belong to the adult side, but they have a lot of experience. So, and they treat children, but in biliary atresia, we've never tried. We have never tried.
Thank you, Javier. Thank you, Mark. Pablo, for the time, the next slide.
Yes.
The next slide. You talk, Pablo.
Yeah, I think Mark was very clear to say that the first question, obviously, the earlier the better. I think that goes for every version, every variant, everything. And then doing a Kasai after 90 days or even 100 days or even later, in principle, is not good. But I think Mark showed the numbers that even after 100 days, the clearance of jaundice is, somewhere around 40–50%. So if you're one of those lucky, you would rather get a Kasai rather than a transplant right away. So, I don't think we can make a final conclusion, but I don't think you can rule out a Kasai or disregard a Kasai just based on age only. If there are other preoperative parameters that you want to use to determine whether you're going to go for it or not, that's fine. But I think the conclusion of Mark's talk was that a Kasai can be certainly offered beyond 90 days of life. Javier, ¿tienes alguna opinión al respecto? Do you have any thoughts about this?
I think that it depends of the state of the child. Mm-hmm. I think that you can do it, but if the child has maybe ascites or you see that he had, I mean, his condition is poor, I don't think that. I think that you should wait and list him for liver transplant directly.
Mm-hmm. Good. Horacio, any questions from the audience about this?
Guillermo, question about the age at surgery. And we had some patients with worsened general clinical aspect, and we decided perform it with liver primary with first option. Any comment?
Well, I think, hi, good morning, Mark, good morning, Pablo and Javier. We did more than 300 liver transplant in biliary atresia, and 20% of them we did like a primary liver transplant, because I think one of the things that you say that they did a biopsy in the biliary atresia, sometimes in our country is difficult because the diagnosis is delayed than another country. So we have a lot of kids that's coming more than 120 days, and in these cases we discuss with Horacio and the people of the general surgery, and if the kids have some kind of sign of portal hypertension, like Javier said, ascites or bleeding or the albumin is so low, something like this, in these cases we decide to transplant primary. But I want to know what is your opinion about, and what do you decide to liver transplant or go to the Kasai in the kids that is more than 100 or 120 days of life?
Well, I would say that everybody would agree that if a patient has liver failure that is, close to end stage, it would be easy to make the decision. The problem is that there are no formal criteria to determine whether a patient will be a candidate or a better candidate for a primary versus for a late Kasai. Let's put it that way. You just said if there is a little bit of that, a little bit of this. But I think there has to be some specific criteria to say these patients should not undergo a Kasai. We don't have those criteria. There have been some primary transplants here, but I think it's just more of a clinical impression rather than a number of criteria. Do you have any sort of specific protocol, Mark, to determine one way or the other in a patient that comes late, or is just your gut feeling, so to speak?
It's judgment, to be honest. It's a conversation.
Yeah.
Now, obviously, if they come in at 140 days, 150 days, it's a very short conversation.
Sure. So because you assume that those livers are already irreversible, but there are some places that are where the lines are more blurry, right?
Yeah, I agree. And if the child, even at that age, I've done them at that age. I've done them at 200 days, and some of them you think, actually, this is a different type. Mm-hmm. Maybe even an acquired biliary atresia, and there's a higher proportion of type 1s in them. Mm-hmm. And that may be a representation of an ischemic event that's happening perinatally, we'll say. So they present late because the disease is late. and they actually do well. But trying to sort that out without a laparotomy, without a cholangiogram, is very, very difficult. So it was a real decision, I think, 20 years ago, 30 years ago. But nowadays, we do have an option, a different option. As I say, the only thing I try to emphasize, you still got to get someone's liver in it. And if your waiting list is long, these infants may die.
Mm-hmm.
So you need to know who's going to give the liver, where's it going to come from, what is the history, how long do these infants wait, to be realistic, really.
Yeah, and also have an honest information about what is the outcome of the transplanted patient.
Absolutely. Yeah.
Transplanting a 6-month-old, individual that is already in bad shape is not guaranteed to work all that well either.
Question: age at surgery depends of the possibility of the liver transplant also. Donor in general is a very important point, no?
Yeah, I think so. I'm not sure if I understood the last part, but yeah, we said that age plays definitely a role.
For finally this point, the treatment of biliary atresia should be sequential, Kasai and after liver transplant. Is okay?
The vast majority, yes.
Yeah, ideally it would be only Kasai, but if that is not possible, yeah, sequential. And then there's those, cases where the treatment might just be a transplant.
Okay, Pablo. Next slide. Mark talked about the procedures, the surgery. In this case, porta hepatis in the picture of the right, and the question is why anastomosis? What is the centimeters necessary for cut the porta hepatis in the liver?
I think Mark mentioned this in his talk.
Yes.
What Mark was saying is that you need to go very wide on the dissection. And the reason is that most likely the biliary tree follows the path of the portal vein. So the wider you go, the more ductals you're going to catch. We follow that same principle here at CHOP. But I know that some people, like Mark mentioned, in Asia, they just do a very, very, discrete dissection in the center of the plate, and that's all they use. Over there at the Garahan hospital, what do you do? Like an extensive dissection or a more discrete dissection?
Extensive dissection, yes. Pablo, Javier Bueno talked me about this point. Javier Bueno, any comments on this point?
I have a comment. We use also the extensive dissection, but recently we have a webinar with Joel Casares from Mexico. He's doing laparoscopy biliary Atresia, and he spent like several years in Japan with the group of Yamataka. He had very nice comments that I will translate to you. So he said that he doesn't make the extensive. It's like Pablo has said that it's just in the center of the plate. He explained, and this group has a survival with the native liver around 80%. That it surprised me. a lot. He said that the original description of Kasai was this small dissection of the plate, not the extensive. Ohi, that was the doctor who followed Kasai in the hospital of Kasai, he started to make that wide dissection. So they analyzed data from the Kasai era to the Ohi era, and they saw that the Kasai era has better results than the Ohi results, and were also almost in the 80%. So that is the reason I think that now the laparoscopic approach can be done. If you use the radical resection of the pediatric thing, that you can make the anastomosis. It's very difficult. So that is my comment, that maybe we don't need to make that radical resection of the plate.
Okay.
I don't know if Mark has some point or some comment about, or if he heard that that explanation.
I've written a couple of chapters actually with Yamataka, and Joel worked in Japan. He was part of the team in Tokyo. What I haven't seen from Joel is his own results in Mexico City. So he quotes Japanese statistics. And
no, he said that I think he has done about 15 biliary atresia and has the same results that in Japan.
But it can be long term because he's been there for what, 2 years or so. It can't be that long term.
As I say, if you get that kind of result in Mexico City, you're doing very, very well. So that in Japan, they've got the best results. There's no question, both open and laparoscopic. But they keep their infants in for weeks and weeks and weeks, and they pump them full of steroids. So they've got a different approach to us in the West. And your point about Kasai versus OE, when they looked at the results, when Kasai had retired, OE's results were better in the long term. And what we do is probably an OE dissection, not a Kasai dissection. And the current person in Sendai, Neo, does that kind of dissection. So it's only Yamataka that has gone back to that. And that's because you can't do a proper radical dissection using the laparoscope. It's just too delicate, I will say, or difficult to do laparoscopically. So it's been forced upon him.
Próxima, Horacio.
Pablo, next slide.
Yeah, we talked about it.
Mark talked about this point, and I like discuss this point. Javier Bueno and Pablo, Javier, do you perform laparoscopy or open Kasai?
No, we are interested in laparoscopy, but we didn't have any attempt yet. So all of our cases has been performed by open surgery. You need to have an appropriate instrument, and that is the reason why we have that webinar with Joel. And appropriate instruments and has a lot of tricks to success. And also to perform in 6 or 8 or 9 hours, you know. I think that in open surgery, it takes to us like 2.5 or 3 hours, the Kasai procedure. So.
I just, we don't do laparoscopic Kasais here. I just struggle to find the point. I struggle to find what is the goal. How would the advantages of laparoscopy apply in this particular context? I mean, I don't think the cosmetic point is a big issue for these sick kids. And the adhesion for an eventual transplant, that's very very debatable. There are studies that say that the bleeding is the same, that the operating time is the same. So I don't know. I think also you can do a better job open, but you know, I don't want to be negation, like, you know, negate advances.
Okay. Any question about this point? Next.
Yes, I have a. I am agree
Yes.
partially with Pablo. I think it's the same reason that you perform the choreographer cyst by laparoscopy. You can do the biliary atresia. Of course, that you are much more comfortable if you do that, if you perform that open. But if you have a good laparoscopy experience, maybe it's a good option, but not with the radical resection. You need to do like in the Japanese way, with that has been reported by Yamazaki.
Okay, fair enough. Yeah.
Pablo, next slide.
Dale.
¿Por qué no me pasa? Open discussion. Predictor of outcome. Age of surgery, liver fibrosis, and biliary atresia type. This point had discussion. And what is the necessary time of cleaning of jaundice to consider a successful Kasai? Mark? Professor Mark Davenport?
Yep. In terms...
About...
Go on.
Yes. Yes.
So the predictors, I talked a little bit about age at surgery. But you've got to have a big enough series to actually show it. So there's no question age at surgery has an influence. But it is also important to recognize the fact that the variants have different ages at surgery. So the ones with the syndromic ones come to surgery earlier, the cystic biliary atresias come to surgery earlier, and the CMV come to surgery later. So it's sort of a combination. In terms of the syndromic ones, we just published a paper on the association with cardiac anomalies. Because some of them, a small proportion, will have significant cardiac abnormalities. And it is important, they are very, very delicate babies to handle. And sometimes it's the cardiologist that talk to you about what you're going to do with these babies. And what we found in our series was that you really should make the cardiologist or cardiac surgeon complete the cardiac therapy, not just do a Kasai operation in the hope that that will work. Even a cyanosed baby that's still got to have its cardiac surgery. Liver fibrosis, clearly it will have an effect on outcome, but if you establish bile flow, that can stop the effects of the fibrosis. So the key thing is establishment of bile flow, and that's actually a post-operation prognostic feature. At the time of the surgery, you can't be definite about anything.
Good. Thank you, Mark. And then as regards the second question, I don't know if there is such thing as a successful Kasai in terms of time, but what would you call a successful Kasai?
Well, the one discriminatory factor is, have they cleared their jaundice?
At what time?
You have to have a level. Our level is 20 micromoles per litre, which is, what is that? Just over 1, I think, milligrams per DL. The START trial, I think, used 1.5, 25 micromoles per litre. If you put your level of clearance up to 2, 3 milligrams per DL, then you're fooling yourself a little bit.
Mm-hmm.
The time it takes, virtually all will clear in 3 months if they're going to clear. We don't really see anyone at 6 months struggling across that line, though.
Perfect. Yeah, that was clear. So you would say that if within 3 months there's no good news, that's the end of it.
That's it. Yeah.
Perfect.
Pablo, is there a question in the chat?
Here they're asking if they make a frozen biopsy of the porta hepatis during surgery.
Typical question.
Mark,
Typical question.
yeah, Mark already answered. You want to say it again, Mark?
So the point is of doing a radical resection is you can't do anything else. There is nothing more to take away. If you were doing Yamataka's operation, maybe you have a choice about doing a deeper dissection, but for most people that resect the entire biliary tract, the extrahepatic biliary tree, you can't do anything else. And as I say, I mentioned coring of the liver, and that does not work. You're chasing it into the liver substance itself. That doesn't work. Frozen section, I think we gave that up 30 years ago. Has no role.
Pablo, about this point, or Pablo Javier? Any comments?
Mark. We don't perform that.
We don't either.
Okay. For the time, next. Other point in relation of prognostic, centralization center. Mark talk about this point. Pablo, your opinion, and Javier.
Who should do the same?
Dale, Javier.
I think that experience. We don't have too much cases of biliary atresia, and I think that the child or the children can get much better prognosis if the operation is performed by experienced surgeons.
Yeah.
So I think that is a good point.
Preguntarle cuántos Atresia al año tiene.
No, tremendous.
Question, Javier, how many biliary atresia per year have you?
It depends. Sometimes 5, sometimes 8, some years. Okay, so usually above 5, but less than 10.
In our hospital, 10 per year.
At least 10 a year. Yeah.
Yes, and Pablo, in CHOP, how many?
Yeah, we roughly see 10 a year, somewhere there. Some years is 14, some years is 8. Which is also the surgery is only done by just very few surgeons. I wanted to say there's a lot of background there. The issue with centralization needs to be considered from a few different points of view. Obviously, it's ideal, but it works great in countries like England, for instance, and Wales, where they have the NHS system. So everybody has to follow the rule, and the transport, like between places, is efficient. If you try to do that in places where there's no universal health system, it will take months, not months, but weeks to move a patient from one place to another. So you will lose, the benefit of centralization by wasting 2 weeks in waiting for the operation. But obviously, in the ideal world, like probably closer to England, you would have everybody concentrated and just a couple of surgeons doing all the cases.
In Spain, it's not centralized by the government as occur in England.
Pasamos a la próxima, Horacio. Next one. This one is about adjuvant therapy. I think Mark already talked about it. The funny thing with the steroids is that everybody believes it, but the one randomized trial done here in the States said there's no benefit. But as Mark very well explained, it was a matter of statistics, not maybe a matter of clinical observations. Here at CHOP, we do steroids. Absolutely, yes. A pretty high dose, actually. And I know for a fact that Mark strongly believes in it. Javier, do you guys use steroids in Spain?
Yes, we use the same protocol as for liver transplant. 5 milligrams this first day, 4 milligrams of methylprednisolone the second day. The 5 day we leave the patient 1 milligram per kilo, and then we decrease progressively, and we leave the steroid for 1 month.
1 month.
So we treat 5 months. Oh, sorry, 1 month of steroids.
How about in Buenos Aires?
Pablo,
and I don't think that it's a big deal with the infection, with the steroid, high dose of steroid.
Pablo, here in Garrahan Hospital, we don't use steroids. This point is a point of discussion with the pathologist and for this point, but we pathologists, no? We don't use steroids.
And what is the reason?
We use urso, and we don't use antibiotic. No, don't use antibiotic.
Have you told your pathologist you can't use formalin?
¿Qué dijo?
Que digan a los patólogos que tú.
Ok, Mara, ok.
Mira qué tal la
Te está ahí, hay una ahí.
Sí, te va a enojar.
Pablo, the pathologist listen to Zoom, eh? Pablo, next slide.
Yeah. I think we're over time.
Sorry, Pablo. I would like to ask to Mark for how long does he treat with steroids? Because I think it's a very important question.
So 5 weeks.
Okay.
So we start off at 5 milligrams per kilogram per day and tail it down over 5 weeks. So the start trial, I think, was 13 weeks.
Yeah, we use the START protocol, and we have them on for 13 weeks total.
Yeah. And also I heard to Mark say that he doesn't treat with Usachol. Maybe it was I misunderstood or not. Say
that again, sorry?
No, if you use also the folic acid in the postoperative period.
Yeah. So yes, they go home on Urso, but Urso will not change the clearance of jaundice. I think if you've got no bile coming through, then nothing will happen. So I think it's not an important thing in the immediate post-operative period. So we do they go home on Urso, yes.
Okay.
Mark, Urso 20 milligram per kilogram per day?
Oh, probably.
Okay. Pablo, is there a question in the chat, Carolina?
In terms of the patients who were treated with steroids, they are asking the same questions that most of that you had an answer already. But they ask if you redo the port hepatis.
Redo port hepatis.
Redo Kasai?
Redo Kasai. Mark?
No. It's if you've done the correct operation, then there's very little you can do. The only time I've ever done a redo when someone else had done the previous one, and they were very inexperienced, clearly, and they'd put it onto the wrong part of the portal hepatis, and that would be the only reason to re-explore. There are later reasons, perhaps, if you get recurrent cholangitis, usually typically after 2 years of age, and there may be a problem with the roux loop. So I have re-explored those. but they're not. That's not, I don't think, what you quite mean as re-exploration in the early postoperative phase.
Yeah.
Okay, thank you. Pablo?
Yeah, I think we only have one or two anecdotal cases of patients that were doing very well, and then from one day to another, they lost their flow. But I think it's anecdotal. It's not a routine. It's not a strategy to make things better in general.
And what did you find there in the redo?
You know, to be honest, I did not do those cases, and they were a long time ago. But I just only know them because I have the database. But, I meant to say that it's anecdotal. Yeah, I don't think it was something that led us to do more.
Sometimes I found some obstruction of the Roux Y, and probably this is the reason that the cholangitis or growing up the bilirubin. I think it's like Mark said, it's 2 or 3 years after the Kasai and start with going up the bilirubin, and in this case I found an obstruction of the Roux Y.
In your series, what is the percentage of cholangitis in the postoperative of Kasai?
Yeah, so in the UK, well, in King's really, it's about 20-25%, and that is the big prognostic feature if you've cleared your jaundice. So the ones that clear their jaundice and then go on to need transplant in the next 5 years or so, that is the one thing that demarcates them, if you like. And that's why I'm trying to look at more ways of preventing cholangitis by extending the period of antibiotic. Those that get cholangitis post-operatively and are not clearing their jaundice well, that they will come to transplant.
Pablo, a question. Mark, Pablo, Javier, one question. Cholangitis is sign of the good bile flow. Cholangitis is sign of the good bile flow.
I think it's probably the opposite. Go ahead, Mark.
Okay, so I was partly true that actually. So if you get no flow at all, and 10% of babies you do a Kasai, it doesn't make anything, no difference at all. They don't get cholangitis because there is no way for the organisms to get from the Roux loop into the liver. So paradoxically, you have to establish some form of bile flow to get cholangitis. So that's what we've observed.
No sé si Pablo, Javier, any comment about the post-operative complication?
No.
Javier?
I have another question. Is the role of phenobarbital, Mark? Do you use, as an example, did you have cholangitis because you have a poor flow? Do you use phenobarbital?
So we started with phenobarbital 30 years ago. Alex Mowat, who was one of the very early leaders of pediatric hepatology, that was his protocol to use phenobarbital, and we have used it up until about 5 years ago. And then we stopped using it. Hasn't changed the incidence of cholangitis, I have to say. And the current people that control it, the pediatric hepatologist, will not re-prescribe it. So there are still older children still on phenobarbital, but it's not part of our protocol now.
But you use phenobarbital when you are performing the nuclear medicine scan?
No,
scan?
I don't think so. I don't think we prep them in any way.
Yeah.
Okay, Pablo,
that's not next slide.
Next slide. Point 1 and 2.
Yeah. I think for the question number one would be what are the the predictors that will tell you whether the Kasai will work or not. I think we talked about age. We talked about the syndromic versus not syndromic versions. And I think, it's a daily struggle to try to find, predictors that will guide us. I think we've talked about all the ones that are available. And the question number two, I think that's a wide open one. I don't think there's a very, very specific criteria. There are after the Kasai, but I guess you're asking, this is after the Kasai. Well, I wonder, I think it's probably the same criteria than for any other indication for a liver transplant to some degree.
Guillermo, talk about this point. The indication is
after failure Kasai, and also hepatopulmonary syndrome, in some kids bleeding, like portal hypertension. This is the reason that we transplant when the kids are more than 4 or 5 years ago, 3 years of age. But the principal indication is the failure of Kasai, of course.
Yes,
okay.
And actually, I would like to point out two issues. One is the pyelomas in patients who are jaundice-free, and they have a cholangitis or infections,
yes,
and they have multi-resistant bacteria, and you can treat with meropenem, imipenem, or whatever, and you can. So those patients need to be listed. And also, I don't know if you, Guillermo, that is nice to hear you about the resistance index in the artery, because sometimes because this patient has a very poor portal flow. The artery is almost the only source of blood. When the index persistence index in the artery is very high, you can have like a necrosis of the liver, and then you need to go for emergent liver transplant. I don't know if you have experience with that. We have several cases here in the old times, and it's just to point out those issues.
Okay, next slide.
No.
Okay.
Okay.
So I have a question that we didn't talk about that. It's about the cholecystoportoenteroanastomosis. In those cases of common bile duct open. I don't know, Mark, what is your opinion about that?
Repeat. Well, can you say that again, Javier?
To use the gallbladder to perform the anastomosis in those cases with common bile duct open.
Yeah.
Yes.
Gallbladder Kasai. Yeah, I've been threatening to do that for 20 years. I've never done it. The next time I move to Paris, I'll do it.
Yes, I know.
Yeah, the gallbladder doesn't allow you to do a wide anastomosis. It's,
Acá se hizo un par de...
Sí.
Y anduvieron bien.
In our hospital, we had we performed some patient with biliary atresia proximal, and you use I use the gallbladder for the anastomosis. Any comment? Any comment about some points? to end the Zoom.
Davenport no.
To end the Zoom, for finally, thank you, Mark Davenport. Congratulations, excellent lecturer. Thank you, Javier Bueno, friends. We went in Pittsburgh in 1990, I don't remember the years, and our friend Pablo Laje, thank you for all. Thank you for all.
You're very welcome.
That's been a pleasure.
It's been an absolute pleasure.
Do you have a question?
Oh, okay, Mark, I listen.
Can we go to the restaurant now?
All right.
Thank you.
Have a good day, everybody.
See you the next time.
Bye.
See you next time.
Thank you very much.
Thank
Thank
you.
you.
Bye bye.
Bye bye.